A very warm welcome to the 2024 edition of the teaching course of the WMS. This has a very long tradition, so therefore I'm very glad to see you all here. And the crowd is getting bigger and bigger. So we started at the beginning with 30 to 50, and now we are over 100. And what we need to do today, and therefore we need to stay with the microphones, but also in time for the presenters. We have also people online. So this is live taped, so that people are online. They're also joining us. So greetings to those out at the speakers and screens. Very warm welcome here from the wonderful city of Prague. You see here the panorama of the city. It's an excellent place, excellent morning. And we have really a world-class faculty here with us. So my name is Benedikt Schoser. I'm the course director here of this. You all can blame on me. So if anything is not running, just come to me and tell me what we can do better the next year. And first of all, I'd like to introduce you also to our tech team here in the back. So there is Michael. So he's the best trained neuromuscular technician we ever have, because he was joining me for a lot of courses, so he knows all. He will be the one who's doing the quiz with 100% normally. And aside to him is Andy, a colleague here from the Czech Republic. Also, thanks for joining us and for helping us here. Without further ado, I will start. And what do we need to have first line? So, how to assess adult patients. So we will start with this. As you know, I'm very much into this so-called Gestalt approach. How many of you have ever heard of Gestalt approach? Oh, these are the coming back people here. Not all of you will know that. So a lot of it's about phenotyping, but sometimes phenotyping is only the start of this. So I have no disclosures. That's a good thing here to this presentation, to another. I have a lot of disclosures, but not here. And let me start just with the introduction. You all be very familiar with the classification of the disorders. We have anterior horn, nerve, neuromuscular junction, muscle fiber disorders. And of course, which of those are really inherited ones? You can see that, of course, SMA and parts of the ALS spectrum. And if you look at the ALS spectrum, there's now more than 50% also including hereditary causes. And we have the congenital myasthenic syndromes, the neuropathies you know very well. And of course, all what belongs to the muscle fiber is very well guided by inheritance. And in some of them, you will find some overlap. And we have still some disorders where currently we think they are acquired. But, well, later on, perhaps we will see something else. I'm very into this also, this immune parts. And here, one of the key things is the inclusion body myositis. I still think we will see something in that also belonging more to a hereditary part of it. And so this is just for reminding you, so what is the background? So how to start? So this is really the scope of the things. And the first thing I always like to tell you, take it easy. You only can describe what you are realizing, what you are seeing, and what you are knowledgeable about. So, and that's something the course will help you in the guidance. So we need to take very classic the history, the examination. We do have then secondary investigations. And of course, hopefully we end up with a diagnosis. And it's in the beginning normally a working diagnosis. So we start to have ordering our symptoms and signs together to a syndromal diagnosis. So that's the current way in doing it still. So ending up with a limb girdle phenotype and things like that, that's very important. And then you redecipher what is really beyond this label you investigated. And of course, history are symptoms. History will give you the symptoms, and examination gives you the sign. And therefore, this is so important to keep that in mind. And then you can start with the Gestalt approach. So what is Gestalt? What is this? Yes, that's Gestalt. You immediately know it. You see it, it's Gestalt. It's very easy. You know it. It's imprinted in you. You know this is a seagull. And if we go here for the different birds, so a bird watcher who is very well trained, he knows the shade of the bird and he can immediately say that's the Gestalt of an eagle or whatever type of things. And similar approach you will have finally if you're trained in neuromuscular disorders. And here another example. So this is an orca, a whale. Yeah. But if you are a trained whale watcher, you can give them a name by the wharf. So the different size of the wharf, the different shape of the wharf will give you a clear name. This is Eddie. He's coming again. And this is so interesting. So this is really Gestalt approach. So you have really a clear point in it. And here another example. Of course, these are lions, and birdwatchers and naturalists do see the characteristic impression that is given by a species or by a plant. And therefore, it's a type of specific shape and design of an object. And that is what you're really doing with your patients. This is a type of categorization you are learning. You are learning by seeing, by realizing, and you need to describe what you are seeing. So therefore, this is something that really takes a while. Oh, this is now an automatism here. This is a bit too quick. Also, I'm quick. And what we do, if we start with the face, of course, we look for dysmorphic pattern. We look for temporal muscle atrophy, for ptosis, for buccal weakness, and for tongue. And here an example. So this phenotype, what is this phenotype? Some of you will know immediately. Yeah, I've heard it. Schwarzschampel. And if you have seen one patient with Schwarzschampel, you will recognize the second immediately, because this has so characteristic features. There's hardly any other disease who has this type of. It's super rare. I have seen only 2 in my life. It's super rare, but if you realize one, you will have the second immediately. And that's not true for many other neuromuscular diseases, but some of them, yes. And this is so interesting, and of course, that's Schwarzschampel. And if you learn all this, you realize how easy you can decipher this in the beginning. What about this? Temporal atrophy. Yes, Steiner disease, and what else? In some regions of the world, myotonic dystrophy type 2, so my favorite, you know it. So therefore, also in myotonic dystrophy type 2, you may have seen that. And what about the faces? What can you do with the faces? Of course, you look for ptosis. If this is a dynamic or fixed ptosis, is it on one side or on both sides? If it's bilateral, you also need to consider other diseases. So borreliosis is a very frequent cause of a bilateral ptosis in patients. And of course, then all what we have for our neuromuscular diseases. And a lot of these are, some of them are very easy to decipher. Others you will need a lot of extra investigations to get at this, especially in the differential, in the later stages of mitochondrial diseases versus a myasthenic disease. They're sometimes not easy to decipher what is what, and here you need help, of course, in the things. And here again, buccal weakness. So this is a very favorite of mine. So there's all patients are agreed that I can show that, and you see here the horizontal smile in the patient, and also this is FSHD1, and you have this tent-like mouth, a very common feature for congenital myotonic dystrophy type 1, and if it's later stage, so 10, 20 years later, you even see that more clear, that picture. And that's something you can easily, just by seeing and giving them hints how to do that. And the Dutch colleagues, and together with also other people, did a very nice type of assessment how to do that. So they ordered this, and this is something, I don't go here in all these details. You can read that and really give you 15 minutes to look at this. It's very interesting to see how they organize it, the assessment of facial weakness, and then finally they can decipher really by the disease. So what happens to the mouth? So is it asymmetric? Is it showing the teeth and things like that? Forming is important. And this will also help later on really to classify your diseases. And why is this becoming so important? Because we want to treat these diseases, and we are in the stage on treating these diseases, and therefore we need to look at all these signs. And there's a very good example here for the assessment. So that's from a French group. They also did it very nicely. Different types of weakness, and by the different tasks, at least, you can easily decipher between an IBM and an FSHD. Many of you will say, well, I don't need a face for IBM. I look for something different. But anyhow, sometimes it's needed to look at this as well. There are subtle subtypes of IBM in the beginning, so therefore also this is rather important to be seen. Another interesting thing is, and there's still a lot of work to do, so there are a lot of young people around here, so therefore I really face you that you promote a bit more work on this is the teeth and the tongue in our neuromuscular diseases. That's something completely unrecognized. It's especially in the congenital myopathies, very important. So we all know about the difficulties of swallowing and of the macroglossia and things like that. But tongue myotonia is also interesting. And then you look at this, you see hypertrophy. It's an element of Becker's disease, of Duchenne, but also, of course, of Pompe disease, and early bulbar spinal muscular atrophy is there. Myotonia, tongue myotonia, if you have ever tested this once in your life, you will do it again and again because it's so easy, but it gives you clues for the diagnostic things. And it's most common in the sodium channel myotonias. And let me see if this works, yeah. And of course, fasciculations and tongue atrophy. And there's another disease included here, the amyloid TTR also can have this, and it's very interesting to see. Of course, this is Kennedy's disease. The perioral fasciculations in men is such a classic hint for the disease. There's hardly any differential in this. And of course, if you then look at the atrophy pattern also on the hands and fingers and the extremities, then you definitely know what is here the part in it. Let's move forward. Another thing, look at the scapula. Look at the scapular winging, polyhill sign. Look for atrophy of the biceps. So it was just a very interesting thing just a week ago here in our inpatient unit. And here, that's scapula. It's always a little asymmetric. And you would clearly say, well, this could be FSHD. And if I show you this one, you would more clearly say, is it more asymmetric in this patient, what you realize, what he's doing. But scapular alata and scapular winging is not only FSHD, so please keep that in mind. It also can happen in multiple of the limb girdles. It can happen in IBM with Paget bone disease and frontotemporal dementia, Kennedy syndrome in the beginning before they really have a complete atrophy, and also seen in Pompe disease as well. So there's a whole bunch of things, but you need to recognize, but if it's asymmetric, it's most likely FSHD1, definitely. So there's hardly any other diseases so asymmetric with FSHD. And the biceps atrophy, this is also a very funny sign. So you lose the lower part of your biceps. And there's only two diseases where it's clearly described. It's an octamin 5 related disease and also in dysphalinopathies. So this is so easy. And what is the other decipher? The biceps atrophy and this compared with a very high CK. So there you already. And if then you have also an atrophy of the caput medialis of the gastrocnemius muscle, then you're more aside on anoctamin 5 compared to dysphalinopathy because normally you have then the full atrophy. And this one is another classic. That's the one I always love. So what is ongoing here? So what is your best guess right from the beginning? Can't hear? What is the best guess for a disease? What could be the disease? IBM, right. And what could be the differential? So it's the end part of the fingers, they can't bend. That's the start. And normally it's on the ulnar part, and then it moves forward also to the medial part of the thing. And the only other disease where you have similar things is myotonic dystrophy type 1 in the beginning. Also, they cannot bend the end part of the fingers. This is the only one, but of course they have a different pattern on top of it. But here it is. And consider this how functional impairing this is for the patients. So it's finally really, they are on the same stage in a different time period as an ALS patient, but the ALS patient has this in, I don't know, up to 5 years, and the IBM patients, they have this within 12 years and have a high burden. And here you see the gestalt change, so you see the atrophy over time. So that's 8 years, and here 10 years, and also here you see the atrophy of the ulnar part of the muscles as well. And then the complete loss of function. The only one who rescues you for a while is your thumb. The thumb is the only one you can use for a while. Gait pattern, also, we could do just 1 hour on gait patterns. Very interesting, and of course then funny things like the hanging big toe sign, that's very interesting. So let's move the people here. All right. This guy here on this side. You see that here? Okay. What can you see? What can you realize? What is preserved? The hamstrings? Yeah, but the only really preserved is the quadriceps. And it was the old description, quadriceps sparing myopathy. Right, you know it. So it's easy. So if you have seen it, you can realize it. So therefore you have to look at all your patients and you have to do it again and again, and we all have our blue Mondays where we don't see anything. We can have the clear pattern and we don't see it. Okay, so that's G&E. And up here, the lady, it's a bit more difficult. Look at the lower legs. It's not easy. It's a distal myopathy. It's a dysphalinopathy. So this one is not that clear. But this one is very clear. Waddling gait, you see? What else do you see? Hyperlordosis, scapular winging. Oh, I'm too quick here. Sorry, going back. It's Pompe disease. Yeah, so this one is Pompe disease, very classic at the beginning. Yeah, you see it, paresis also of the abdominal muscles here as well, hyperlordosis, scapula lata, and also this waddling gait. It's gluteus medius atrophy in that. And the last one here, this is the combination of a proximal and distal paresis. You see, he's hardly able to walk, also preserved the quadriceps muscle, but this is a combination. And on top here, why he's so unstable is also a neuropathy. So therefore, it makes life much easier if we know the disease and then describing it. But sometimes it's really an easy picture. You can decide by the gait traits. And of course, that's the hanging big toe sign. That's very common. What is the only differential you need to consider? It could also be an L5S1 syndrome. So that is, but it's bilateral, and you have a neurogenic pattern. And then if you do really the muscle MRI, then you see it very clearly. And of course, this is late onset distal myopathy with 2 types of mutations we know very well. And frequently, it's also with the thumb and index weakness, index finger weakness compared. So this is very common here. Okay, what else? So we have rippling, mounding, we have grip and thumb myotonia and myogenic tremor, something new over the last years. We did know that. And of course, that's pressure or percussion-induced slow waves. So that's calcium waves. They are electrically silent. That's a very interesting part in it. And of course, with the Cavalin 3 mutations, you have a very nice spectrum of just rippling muscle disease, just hypercyclemia, and the full picture of limb girdle muscular dystrophy. So there's all in it, just depending where's your mutation, if it's more recessive or a dominant mutation. And also you can have this in combination with myasthenia gravis as acquired rippling muscle syndrome. So this is also interesting to see. And the other one, sorry. It's moving by itself. And here that's the so-called mounding of the muscle, also very typically for a rippling muscle disease. So you do a percussion and it's not like a percussion myotonia, it really stays like a mountain in the muscle. But it's only in a few exceptional patients. It's not really completely common in rippling muscle disease. And of course that's more easy, you all know that, but interestingly is also the thumb myotonia. So it's not only the full wrist myotonia, but it's the thumb that's also handicapped. This is now very important. It's one of the key outcome measures for myotonic dystrophy for all the antisense oligo trials, what we are using, looking for fist opening time, video controlled, and that's important. But of course, we have it in other diseases. You sometimes see it even in Pompe disease, and a very common acquired disease is hyperthyreosis. So there you can see really this type of myotonia. It's not that exaggerated, you see it in myotonic dystrophy type 1. And here's the full phenotype. Cushman-Steinert is perhaps the most easy. So here, who in the room hasn't ever seen a Cushman-Steinert patient? Is there anyone who has never ever seen a Cushman-Steinert patient? Yeah, and that's the reality. It's the most frequent, dominant adult neuromuscular onset disease with also the congenital form, of course. And it's worldwide, really, with a high incidence. But nevertheless, the spectrum is huge. So there's this end, this is the easy end, but there's a lot of the other really only where you have parts of the symptoms. You can have just a cardiac block and a myotonia. So that's in the late onset stages, and in some of them you have just the cataracts, and in others you have the full picture of this disease. It's a very interesting one. So another thing we learned, and there was a lot of people involved in that, but the NIH with Carsten and Regan, they did a lot of work on this. So sarcomeric proteins are capable to have a myogenic tremor. And this was something completely new. So it's really just now 5 years ago. We were never aware of this before, but it makes so much sense. And the list of proteins is even getting longer. But it's so interesting to see that really a motor protein can give rise to a visible myogenic tremor, even on the tongue side and things like that. So it's not a fasciculation, it's really a tremor. Very interesting disease and was overlooked for many, many years. And we know a lot of these motor proteins, sarcomeric proteins, have really this phenotype. So if you look and see people having this type of clinical signs, then definitely you should look at one of these genes, and especially if you have a family history here. So very interesting thing. And Jochen, is he here? Already there? Yeah. So if you want to know more, Jochen Schäfer can tell you a bit more about this. He is here with us today. So in summary, see what you describe, have a look, and have a look at different time points. Again, we all can have our blue Mondays where our eyes are completely in a different direction and don't realize what they want. I can always tell you the story about Kennedy's disease. So it was so clear-cut, but the CK was so high. I always said, wow, they have the fasciculations, everything, and neurogenic EMG, but the CK was 6,000. I said, oh, well, this is a new disease. This is a completely new disease, and it wasn't. It was just my blue Monday. I did not realize and did not pick up what I should have seen, and so therefore have a second look, a second time, or take a colleague with you. So sometimes this is also very good. If there's a new phenotype, you're unclear to this, take a colleague with you and together describe this. And you need to exercise. So let your patients jump, something that is hardly done in the normal routine examination of clinical. Let them jump. It's very interesting. You see a lot of things, and many will say, oh, I haven't done this for years. And then you realize, yes, some of them can, and limb girdles, if they're really proximal, they can't. So it's a very easy to decipher. Also, you can realize if there's something change in the nervous system as well, so if they have some atactic traits, things like that. And taking the family history is still so important. And you need to go at least for 2, even 3 generations. So come back to this again and again, and the next time and say, well, talk to your mother again, talk to your brother and sister, what they realize from the family history, and then you will decide, well, what is really the trait in here? Is there something or is there nothing in it? So therefore, it's very important. And of course, nowadays, as neuromuscular disorders, so we are ahead of many neurological diseases. We are now really in the age of treating these diseases, these inherited diseases. Start with those where we have already some treatments. So don't go for the super rare things. So this is also for academia super important. But at the beginning for your patients, it's important that you do decipher really the things where we have already treatments in hands. So therefore, all this was called stratabolum. Go for it. And now, a final quiz. Many of you will know this. So what is this? What do you see here? Yeah, it's a beaver sign. And do you know how old this guy is? It's a long time ago he described this very well, and he was described in patient with FSHD, but it's not only FSHD. So there are other diseases. There are some of the limb girdles and also Pompe disease where you can have a beaver sign. And tonight, you can look at your own navel, so what happened to them? can easily realize. This is always very interesting. And at least you go for your partner first. So that's normally the easy way to do it. Okay, so by this, please remind history, symptoms, examination, signs, and trust your eyes, train your eyes, and then you will be a very good neuromuscular specialist. And by this, I stop. Right. Questions?